I come to this really as a minister who has a portfolio that straddles the interface between health and social care. I think it's now increasingly accepted and understood that there are significant interdependencies between good mental health and good physical health. And delivering better outcomes in physical health will require mental health to be given parity of esteem and provision of services. When the media discuss these issues about health reform tends to get couched in fairly negative terms. And integration seems to have become a conversation that is cast almost entirely in negative terms, that change will lead to fragmentation, as if the NHS in its current model is a model of integrated care. Yes, of course, there are some beacons, but what they haven't done is actually managed to transfer that. They haven't actually fired the imagination from one part of the country to another. So this fragmentation that exists now is not the exception. For most people with health and social care needs, it's the rule. The endless phone calls to different agencies, never speaking to anyone with the same name more than once. It's the seeming inability of healthcare workers and social care workers to talk to each other. And yes, we need more co-design and we need co-production, not just between professionals from different agencies, but also with the people for whom those services are being designed. But it's the system in that conversation that actually needs to bend to fit around people. Personal budgets can be an incredibly powerful force for change. They give people the opportunity to identify the outcomes that they want, that actually enables them then to tailor the support and help that they need, and it's a change in the conversation that then takes place, elevating the patient from a recipient to an expert through their experience of the services. There's also a financial case, not least since David Nicholson spelt out the efficiency challenge facing the NHS in 2009. Now, it's about doing things different, it's about changing the model, and nowhere is that, I think, more critical than when it comes to long-term health conditions. 15 million people with more than one long-term condition. And together, they account for £3 in every 4 that the NHS spends. It's about more preventative care, about keeping people in better health and out of hospital. It's about helping people to manage their own conditions more effectively, but also closer connections being made between primary and secondary care, and a growing recognition that it isn't just a conversation between health and care that's required. There's a need to have a wider vision at a local level. Long-term conditions will, if we do not act and change the model of care, bankrupt the NHS. So what are the barriers? Why is it not happening everywhere? For over a decade, councils and NHS trusts have been able to pull budgets and jointly commission services. But these things have not taken root. Leaders at the top of organisations, both in health and social care, don't always do the right things. And there are, of course, changes that we need to make at the top. And that's why the proposals in the Health and Social Care Bill do address these issues. That's why the NHS Commissioning Board, the clinical commissioning groups, health and wellbeing boards, and even the regulators, Monitor, CQC and NICE, will have explicit duties around integration. And then, of course, there's NHS money for social care, and there's NHS money for reablement. But at this stage in the development of our new health and care system, we have an opportunity, I think, to address not just the structural issues, but also the cultural barriers. Let me give you an example of what I mean. Diabetes. We know that about 80% of amputations caused by diabetes are preventable. We know that less than a quarter of people with diabetes take, or indeed are provided with, regular foot checks. We know that health trusts have been successful in reducing amputations where they have introduced regular foot checks. But integration should go further, because we know that type 2 diabetes is preventable, and if there's a vested interest in helping people to manage their condition, surely there should be an even greater interest in preventing it in the first place. Health and care becomes less about how we treat poor health, and it becomes more about how we support people to maintain good health. Now, the innovation and creativity to make this happen, in the end, can't come from the centre. We can remove barriers, we can provide tools and support, and it has to come from the bottom. And I don't doubt the belief that many frontline health and care professionals have about the value of collaboration I've made some visits to some of the places that are at the cutting edge of this. None of what they've achieved was easy. It didn't happen overnight. They succeeded by actually keeping faith with a vision that they had articulated and embedded in their organisations. In the case of Knowsley, they talked about the Knowsley pound. It's an immediate change in the way in which you start to think about whose resource are we spending. It's not our resource, it's the public's resource we're spending on their behalf as their custodians. So in conclusion, look at the patients you see most. Think about how many of their health problems started way before they ever set foot in the surgery, and how little one service or institution working in isolation can actually do for them. And then think about what, if you had a blank sheet of paper, you would do to build community services that actually prevent and postpone and manage chronic health problems. Because if we think in this way, then I think we can begin to make real progress. We can begin to commission health and social care services that really do deliver the prize of integrated care and really do deliver the outcomes we all want to see. Thank you very much.